We are ready to start here. It is 1:31. We will call the Cumberland County Finance meeting to order, and we will begin with a roll call, please, Lauren.
Commissioner Nieder.
I am here.
Commissioner Fashi.
I'm here.
Commissioner Eichelberger.
Present.
And next on the agenda, we open it up to public comment. While we have some folks in the audience, I think they're all here for a purpose. And I don't know if there's anyone online.
Yes, we have a J. Ross online.
Okay. Jay Ross, if you are interested in making a public comment, now would be the time. If you have the ability to use the raise your hand feature and let us know that you wanted to make comment, that would be fantastic. Nothing? Okie dokie. We will move on to the approval of the minutes from the June 11th meeting.
I'll move to approve.
I will second.
It's moved and seconded. All in favor say aye.
Aye.
Aye. And next, the subject for our meeting today, we are having an update on the Connections Crisis Walk-in Center. And we have with us Brittany McCarthy, Kimberly Jones. I think that's it.
Yeah.
Right? Okay. Good to see you ladies again.
You too.
Pennsylvania feels like a terrarium compared to Arizona. I don't know.
Arizona felt like the surface of the sun last weekend. I flew home for my daughter's birthday and it was 110 without the humidity.
Yeah, so here you just get the humidity.
I don't mind it yet.
I
might
can do
will.
without it.
You
Awesome. Well,
Alright,
thank you so
ladies.
much for having us. We appreciate being able to provide an update. I think we were last here in March. I was out on leave, so happy to be back and provide you guys an update. Brittany McCarthy, I'm the strategic account manager.
Kimberly Jones, the VP of Clinical Operations.
Just a reminder, we're going to go through our mission and our service lines, just as a reminder as to the services that we offer.
Hold on 1 second.
Sorry, picture keeps going.
It keeps
turning itself off.
Oh.
Yeah.
Okay. We want to make sure folks can see it.
I just remembered that we're gonna be
I don't, you're the
Yeah.
click share
Yeah.
person, not
If
me.
you guys are okay that I reboot the click share.
Yep, go ahead. We'll wait till they get that up and
Sure,
going, but
sure.
you can go, I apologize, go back to where you were with just the preface for the update.
Yeah, that's great. So that's great. I can just go through our mission and a reminder of the service lines that we offer. Our mission is providing immediate care to people in crisis and connecting them to long-term support in their community. And the different service lines that we offer at our physical location on Cameron Street is walk-in urgent care, 24/7, 365, no appointment needed, 100% acceptance rate. We have an observation unit, a 23-hour and 59-minute observation unit for individuals that need stabilization. Maybe we're unable to stabilize them in our urgent care and they just need a little bit more time with us. We have our 23-hour observation unit. And then we do outpatient recovery services, really a transitions program, making sure that individuals are leaving our program, connecting to services within their community. And in addition to our physical location, we have our mobile crisis response team that responds in all 3 counties, Cumberland, Perry, and Dauphin, with a clinician and a person with lived experience responding as that team.
Let's see if we've got it working now. So will you be sharing data then today?
Yeah.
So will it be all through May, from January through May?
It would be December through April,
Okay,
the end of April. Yep.
thank you.
No. Do we have this?
Yes.
Available to us? That
Yeah,
I can
absolutely.
share it through the use.
Okay.
I can teach it. Sorry. Do we have that file that I can just then share it through?
Yes,
Yeah.
yes.
Or
Do you want it or do you want me to
just,
share?
You have it on the flash drive?
I do.
Yep.
We'll go another path.
Yeah, that's okay.
So you,
Like crisis.
Yeah.
Sorry about that.
if you can remind me, you started with adult
December 4th, we rolled mobile.
mobile.
December 11th was adult service lines, and January 13th is when youth 14 to 17 launched fully. So all service lines by January 13th.
By January 13th.
Mhm.
Okay. So in the data that we're going to see, it will not be full months for all services
Right,
beginning through the year,
right.
but close.
Sure. And the data that we're providing today is certainly an overview
Of com-
of Cumberland specific data. And then if you all want more details on specific service lines or those types of things, we have the monthly report available through the end of May that we're happy to share.
Thank you.
Yeah, sure.
We're
almost there.
almost there. The tech folks are working on getting the presentation running.
Never a dull moment.
Yeah, so off script, how are you feeling about the operations at the facility?
I mean, our urgent care and walk-in volume has been tremendous. And we average 9 adult walk-ins a day for the urgent care line of service. We continue to work with all of our police departments and townships and municipalities in the drop-offs so that we can continue to divert and or be an option outside of the ED or jail. Brittany's done a lot of work with that, and that's gonna be on a continuous basis, working with them. And so we are also, the pilot program for EMS drop-offs, continue to meet with Dr. Bledsoe, as recent as 11 o'clock today, on when
That's
we
with
can.
PMC, right?
Yeah,
Mhm.
and he's the state EMS
Medical.
medical director. So we're working through some of that, which will increase the drop-offs at the back door, so that people can start service at minute 1. But overall, I think it's been going well. It's crisis. Every day is different. There's no standard. We just treat, we have 100% acceptance rate. We have seen every single person that has walked in to any of the doors. And there's always room for opportunity, especially the throughput for the appointments and making sure that our outpatient providers in our communities are willing to schedule those appointments upon discharge. So we're working through that as well. Anything you would add?
No, I think things are going great. I think that as a new service line in the community, it's been a great opportunity to work with our partners to identify the areas where there's bumps or challenges and really jump into action in ways that we can improve. Workforce I think is an issue for everyone. And so we've certainly identified some challenges with our peers. And so our team is actively working on a plan to assist peers with their certifications. If there's a way that we can kind of upfront help them obtain their certification and then work with them to stay committed, to working for us for a little bit. So we're looking at different options as far as overcoming those challenges, but overall, I think things are going well.
I have a question. You said something, you said as long as our outpatient providers are willing to schedule outpatient visits. What does that mean?
So, or it's not in their practice, and I don't know, so what we're experiencing is they just have the patient walk in, or after 5 o'clock, there's no number to call to get that patient scheduled, but we're discharging after 5, like we don't run 8 to 5. So having the ability to make sure that if somebody's discharging back to the community and needs an appointment, that we always have that. If Pennsylvania Counseling Services, I can name a couple that, who are we calling after hours to also obtain that, instead of just saying, please walk in here, because there's no tracking on that, right? We do have a high percent of patients we're seeing that have no access to phones, cell phones, a permanent address. So we have, our unhoused. So how do we make sure they are connected or wrapped somehow especially after hours. You know, at 8 to 5 is great, but that's not the reality of crisis.
Right.
So, and you know, my experience moving out here is we had 24-hour liaisons at our outpatient clinics that we were able to call and get that stuff scheduled. So, you know, and I know that it's a different community and things like that, but it's a cleaner way to make sure that we've done our due diligence and not just keep somebody until 8 a.m. the next morning, right? Because that's not always appropriate either. So
when you say you had 24-hour liaisons at your outpatient clinics, do you mean the ones in Arizona?
mhm.
Have you made any progress with that?
No, I mean, we send, no. So, I mean, I don't think it's an option from what we've experienced thus far, but we are taking a deeper dive into our or the people discharging to the community and making sure, and when I say a deeper dive, it's a lot of training with our staff. Are we calling the right numbers? Do we have the right people? We're calling, so the social services or clinical services manager is making connections with our clinics so that we can figure out how do we connect people? Because the case management units are great. One of them only, like not yours, but one of the counties we deal with only allows walk-ins for adults. And then with the multiple ones in Cumberland County, we can fax a referral. But there's no guarantee that we're getting an appointment for that person when they leave our facility.
I certainly think there's an opportunity to improve the handoff process, and that's what we're looking at is, you know, from our team to the available resources in the community, are we utilizing the programs that are available?
Right.
And are those handoffs seamless? And I think that's something that's been identified. Certainly reviewing the data over the past couple weeks, also since returning from leave. So I was out for 2 months, I had a baby. And so I'm reconnecting with our community agencies, outpatient providers to make sure, like, are they seeing referrals from us? If not, why? And really digging into what it looks like to develop a warm handoff process to them.
Yeah, that I'm so glad I asked the question because this has me extremely concerned. Because as a tri-county, right?
Mhm.
3 counties invested dollars in this,
Mhm.
right? And state dollars came in to do this, a tremendous grant. With the intention, I believe, that we would keep people out of prison.
Mhm.
And we could keep people from having problems out on the street. And so it seems to me like we've hit a snag. And so I'm glad you're working on it, but boy, would I really like to see that
Mhm.
accelerated because we've got to figure that out. I mean,
Yeah.
your model is 23 hours, 59 minutes.
Mhm.
And I know that I've had a conversation with you where you said like, well, if we can't find something to do with someone, we're keeping them.
Oh yeah, we do that. So when we're referring to higher level of care, or, you know, we have made countless, I probably couldn't count on one hand, exceptions past the 2359 to make sure that individual gets to higher level of care, waiting for transportation. We've had communications with the local jails, releasing individuals to us and trying to accommodate the best we can. So we certainly have made those exceptions as far as keeping individuals and getting them to higher level of care. We have had very minimal, and when I say minimal, I think maybe 3 or 4, maybe even too much, cases that we have discharged to hospital. So that was simply a 302 commitment that we exhausted the bed search and we were passing the 2359 and needed to transfer them to the ED to continue the 302 process. Outside of that, we have had no issues placing people at a higher level of care.
Yes.
No issues.
It's getting them stable and they're going out the door and they don't have a phone,
Right.
right? And how are they supposed to get that follow-up? That piece
Sure.
really needs to be accelerated.
Yep.
Because
Sure.
like when I think about what has been invested
Mhm.
by
Absolutely.
3 counties in the state,
Absolutely.
people should be taken care of.
Yep,
Absolutely.
absolutely.
And one of the things is I think about our hospitals, and you know, one of the things that I have personally heard is that they're hopeful that this is a deterrent
Mhm.
to people sitting in their ER for weeks.
Yeah, absolutely.
So we've got to get past that.
Yes.
That is a super snag.
Yes.
So Kimberly, the one question I would ask about that, when you are seeing these folks, if they are currently unhoused, are you asking that question, where are you sleeping?
Yes.
Okay,
Yep.
because sometimes the shelters would be a good point of contact.
We
Yeah.
we even provide transport too. If
Okay.
they're state, like we have a really good relationship with Daily Bread comes up. There's a Bethesda, we connect with weekly probably. And there's another one on Front Street that I can't remember.
And in Cumberland County, we've met with Safe Harbor
Yes.
and the local, I've met with the local Cumberland County shelters as well.
Yeah, or
Yeah.
community cares.
Yeah.
So we're able to call a lot of times and say, and some have been willing to hold the bed, knowing that the patient is coming from us. So that relationship is there. We won't be able to solve for somebody not having a phone.
Right.
That's not, I'm not sure what happened with, there was that across the country, I think the Obama phones and things like that.
But no, I know,
there's
and I am
like,
wondering
yeah.
if there is a way that you can solve for someone needing a phone in the, listen, I'm just
No,
brainstorming.
right.
And this is not
Yeah.
let's do it,
Yeah,
but
yeah.
I do wonder if there is a solution to that may be easier than we think it is.
Yeah, and we always encourage individuals and let them know when they're leaving us that there's no amount of time that they have to wait to come back to us, right? So if they don't have a phone and they struggle, they can come back. They can come back through urgent care. They can come see us again, and we can work with them if needed again. So we're accessible. There's no amount of time in between their visits, or they can't come to us too many. We want to make sure that people know we're accessible all the time. Yeah.
Okay. Good, thank you.
Yeah.
I also have a question. Are you following up with member services with the person's respective insurance companies? If a person doesn't have a phone, I agree that's a hardship. But if the person does have a phone, and if you're trying to schedule an outpatient appointment, could member services from the respective insurance company reach out to the member?
Yeah, that's something else that I know we do perform care for the MA members, the private insurance, as well, especially if we have had to do pre-certs and things like that. So I think there's avenues for sure. When we're working through them, we're figuring it out, and like, that's happy to pivot and figure out how to best support that patient for success. Like, that's the thing. The other thing with urgent care patients is there's such a wait for psychiatrists in the community. So when they come in and are seen in urgent care and discharged with a prescription, then we give them the return. We need to see you in 10 days. Come back and our provider will re-eval, because they don't give longer than about a 10-14 day script for safety for a lot of reasons. So that is an opportunity to check in with them, and they do return.
It does happen. Yeah, we've seen quite a few people that have returned 4 to 8 weeks to bridge until their appointment.
That's good.
Yeah.
I think we are seeing a pretty high amount of individuals coming for medication.
Yes.
Like for that exact scenario. It's been a great bridge, even with individuals who are leaving inpatient treatments. Like we talk about going to the local shelters or other programs. Sometimes they're not sent home with enough medication even to get them a couple weeks into the next level of care. And so then we're able to see them and coordinate with that program until they get back and in with a provider.
Great, thank you.
Sure.
Kenny, you look like you want to say something.
Well, I'm just curious if we could be made aware of if there are hospitals releasing people with inadequate medication supplies with an appointment in the future, because those are things, especially if it's a Perform Care member, we can absolutely work to address. So those are, certainly things that we would like to know about.
Sure.
Yeah, thank you.
Yeah.
Mm-hmm.
Do you guys have any other questions?
I just have a thought rolling through my mind, but I know I'm hijacking your presentation, but
No, it's fine.
as I'm listening to you and Annie has said, boy, we would like to know about that. I think there's a lot of things that I personally would like to know about
Okay.
and get some data and get
Sure.
a hold of it. So
Okay.
I understand what's going on and what the issues are, because we are most certainly a team on this, and there are significant taxpayer dollars that have gone towards this project, and
Sure.
this needs to work.
Yeah, sure.
So, and I know you're new, I know it's new.
Yeah.
Right? And
Please feel free to send, I think my contact information is at the end of the slide, but I'm happy to reach out directly. Any questions, like we come to these meetings quarterly, but I am accessible all of the time. So my cell phone, my email, whatever you're interested in as far as data or process or
Okay.
Things that we're seeing. We have a weekly meeting with our county partners. We have a monthly report out with our county partners as well. And so on all of those meetings, we are presenting data, we're answering questions, we're concerns going back and forth with process or things that we can improve. And so if there's anything that comes up at any time, we're happy to address in real time.
We're always gonna be evolving. That's just what it is, especially in a new community. Like, we pivot and we figure it out as quickly as possible. And sometimes it's not in our time. It's like, how do we get as creative as possible? I mean, the facility is 24 hours, you know, where
I think what we're seeing a lot of times, like when I talk about the hospitals or the inpatient units, a lot of times, like we attempt to keep people as close to home as possible. We go with the two closest inpatient programs if needed to the community that we are in. But if that doesn't apply, what we do see, which has been a common theme for a very long time, which I think Annie, you and Andrea are both aware of this, is they aren't aware of the community resources here. So when they're sending people back with maybe not 30 days worth of medication or a connection to resources, it's simply because they're not in this community. And so those are the things that we hear from like one of the local shelters or something like that, which is why I brought that up. Like that's just something I think that's been happening for a long time, because maybe they can't give more than 30 days of medication or something like that. So that's when we are happy to kind of move in as that bridge appointment and make sure that they have what they need locally.
And I can appreciate you haven't even really gotten a solid 6 months under your belt yet with providing all levels of service that you are doing now. So but I appreciate the discussion.
Absolutely.
And that you're very forthcoming about what you're working on. What needs to be improved.
It's daily. It's like we are at, 19, 20-hour days and elbow to elbow with the staff because they have also never worked this model. So like, I understand it. And so it's like, whoa, we're not doing that. Okay, let's pull this back. Okay, I have to get on a meeting. Like, but that's what this is. That's how we're going to make an impact. Again, I'm really proud that we have 100% acceptance rate. We figure it out. We've had some significant, we've had a significant event with a couple of maybe a month ago where somebody rang our doorbell and had been stabbed 3 times. And we got him in and we called 911 and we got him to the next level of care. That's not what, he wasn't coming in crisis. He was dropped off in a vehicle and rang the doorbell at 5 a.m. Those are things that you don't plan. You can't plan for those. And it throws you know what I mean? So like, it's literally daily. No day looks the same and I'm here for it. I love it. So, we will get there because we are constantly evolving and saying that what is the takeaway from this and what do we do better next time? And that's every single day. So, and we can, we are working to the contract we agreed to, and that is constantly evolving because it's going to be, because you come into a new community and it's like, oh, that's not gonna work here. Okay, we gotta pivot here. Okay, like, so we're willing to do all of that. We have to follow analytics and we have things to do to gather some of the data that wasn't originally asked for. So we're trying to work through that. And we have a process, so it's literally a new baby.
You're in the toddler stage.
Yeah,
we are.
So you have some good data up here. I was just eyeballing.
Yeah, I would love to share that.
Yeah.
So I do want to say, there's always opportunity for growth and things that, present challenges for us, but we are doing really great work. And we've seen a lot of individuals from Cumberland County, also, Perry County and Dauphin. Our relationships with law enforcement are fantastic. As you can see here in the data, Carlisle Police is like one of the top drop-offs, and they are a distance from us. And so that representing, not just the buy-in from law enforcement, but them seeing, the quick drop-off time, the benefit to the patient. We were just talking this morning, we have had quite a few drop-offs from state police, and the state police being one of the departments being in Carlisle. We've had quite a lot of drop-offs from them. And so we are really excited about that, because that means that individuals are getting the opportunity at treatment and maybe not going to jail and not in the ER. And so the data here for law enforcement that shows 101, this is specific to Cumberland County. And like I said, this is through the end of April. I know that our numbers are higher. We've had quite a few drop-offs from Lower Allen since then, West Shore Regional since then, East Pennsboro. And so, we are in constant communication with our law enforcement partners, in addition to the co-responder here in Carlisle. I do want to shout her out. She's fantastic, and we partner really well with her. Yeah, to make sure that the individuals that we are both seeing, that we can, make sure there's follow-up on both ends. Our mobile crisis response time across the region is 19 minutes. This is an average time, which is fantastic over a 3-county region. We do have a team that stages here in Carlisle. Important to shout out Mike Snyder and our 911 partners, opening up space to us in that building, which really cut down on the lengthy transportation time. I think we talked a lot about when we were open, we didn't know where most of the calls would be, right? We were like, okay, we're doing mobile crisis all over the region, but let's see where the data is so we know where to stage our people. And as it presented, we needed a team here in Carlisle. So we have a team here in Carlisle. We have a team staging out of our center in Harrisburg, but that doesn't mean they don't cross county lines. So if a team in Carlisle is on a call here or even further, then our team in Harrisburg will travel to another county, right? They're not bound to those counties. It's just kind of where we're staging them to make sure that we can cover ground. So that's fantastic. We have 1.6 minutes through April, which is the backdoor drop-off time. It's been very quick for our law enforcement partners. They come in, if they have paperwork, our team is quickly reviewing that, collecting collateral information, while at the same time moving that patient into treatment and making sure that they can get back on the road. 100% acceptance rate, front door and back door through urgent care and that backdoor acceptance. Something really important here, I think, to point out is our door to doc urgent care time, 42 minutes and 47 minutes for youth and adult there. Significantly shorter times than individuals would be waiting in an emergency room. And I know this is a public meeting, so I just want to say, if anyone who does present with a behavioral health concern, coming to see us at Connections really cuts down on that amount of time that the individual would be waiting before they're seen, by a team to be able to treat them. And then our average length of stay on observation is 16 hours. So we have up to 2359 with the individual, but our goal is always least restrictive care, whether that's urgent care or the least amount of time on observation as possible. And so we are at 16 hours there. Did you have any questions on the data? All right, so our stakeholder partnerships, I just wanted to provide an update as far as community outreach and awareness, our law enforcement, and then our partnerships with the hospitals. So we are launching, with no definitive date right now, a youth marketing campaign. We want to make sure that the youth in the community know that we have an urgent care for them, ages 14 and up. We've worked with our local schools. We've presented to superintendents and counselors and social workers, and that is in all of the counties I think I've presented. So there's certainly awareness. I think the referring a patient to us, or the transportation, or the way that our mobile team has interacted with the schools has been very positive. Our team can respond to any age with our mobile team and age 14 and up at the center. So we're continuing our school district presentations and working with them to figure out if they're not utilizing our services, why. And some of the things that have come up in just recent meetings are some of the schools discussing an MOU, and can they refer to us if they don't have an MOU? And so most recently I met with Mechanicsburg School District, and we're in communications right now about what would they need and what does that look like to make that a more seamless process for them to utilize our mobile team or make referrals to the center. Every school district is different. I feel like every county is different. Everything is different. And so we are happy to have certain agreements with the schools if we need to. Our team is happy to review those and accommodate as best we can so that it's a seamless process for the kiddos. And then, as we mentioned, ongoing meetings with our provider agencies and community groups to improve our warm handoff process. Law enforcement and first responder collaboration. So we have done briefings in Cumberland County. I only have 3 departments remaining. I have met with every department, sometimes multiple times. I will do a 6 a.m. and a 6 p.m. if I have to. I get in front of the patrol officers to talk to them about really what the process looks like when they utilize us. I have 3 departments remaining, and hopefully I can get to those. Prioritizing our communication with our Carlisle co-responder, who, like I mentioned, has been fantastic. And then we have a crisis activity report that goes to law enforcement on a bi-weekly basis. That is something we newly launched in the past couple weeks. So I'm waiting for all of the departments to be loaded to get on that first report, and then a bi-weekly basis. And what that report shows law enforcement is specific to their department. How many individuals in the last 5-month period have they referred, and what our daily chair availability is, so that they know what is available, in addition to emphasizing that we never go on divert for law enforcement. So whatever that availability is, even if it was less, we always accept at the back door. And then our healthcare and hospital partnerships. We have monthly hospital meetings with Penn State Health, and that has been primarily the facilities that we refer to directly with PPI, Holy Spirit Emergency Department, and Holy Spirit Behavioral Health. We then are scheduling to add to the group our Penn State Hershey partners. So we have those monthly meetings. We meet with UPMC monthly, and we've done an outreach to Carlisle Hospital here in the past couple weeks to make sure that we connect with them on what the process of utilizing and referring to us will look like. And then continuing our inpatient hospital partnerships. And honestly, that's more of a day-to-day for us. There's a contact at the hospital similar to how I'm the external point person for connection. So I'm in honestly weekly communication and daily communication with those partners if we have any referral issues or questions, or a lot of times, you know, if we send a packet out and I'm like, hey, can you review that packet? You know, we want to make sure that people are getting to that next space. So we have a lot going on as far as community engagement that has been, you know, really positive and impactful for increasing our census at the center. Oh, go ahead.
So Brittany, one of the things that I think is going to be really important, and I know you're in communication with the hospitals.
Sure.
But at the end of the year, or whatever point in time you have, you know, your first go round of data, is what percentage of the people that you've seen, and I saw on the prior slide, 600 plus, 680 some, I think it was from Cumberland County, would have presented at a hospital.
Yes.
And I feel like that's going to be critical for the hospitals to acknowledge. And when you're meeting with them, are they feeling that? Are they sensing it or seeing it or not seeing, you know, that they're not seeing it, they acknowledge it?
So I actually just met with Penn State Holy Spirit ED yesterday. They are seeing a decrease. We did hear from UPMC Harrisburg that their medical director sent me an email saying they saw up until this point, since inception of connections, they've seen a 20% decrease. Did I say increase for Holy Spirit? I meant decrease. Decrease, everyone decrease.
I think you said decrease.
Did I?
Yeah,
Okay.
think you did.
And then UPMC Harrisburg has reported that they have seen a 20% decrease in behavioral health cases presenting to the
To
hospital.
the ED.
So I will say, on our data right now, we are validating the diversion data. So I don't want to send that quite yet. As any automatic system, if the value is incorrect, if it's not pulling from the system appropriately, the numbers are not accurate. So for every law enforcement drop off, if we think of it that way, just starting, 101 that we've seen here, all of these are a diversion from something. All of them. They're a diversion from ED or jail in some form or another. All of our 302s would be involuntary patients would be a diversion from the ED. All of our voluntary patients at the back door with law enforcement would also be a hospital diversion, because previous to connections, that's where they would go. And so we are validating that data, and we are going to make sure that it is accurate when we present it.
Perfect.
I just wanted to share here, I don't have to read it word for word, but we had a patient handwrite a thank you
And mail
letter
it.
to us and mail it. And these, I think, are the moments when we can reach out to our team and say, like, look at the great work you're doing. This person who felt significantly happy and appreciative of the services that they received at Connections. This is always something that makes you feel good when you're providing services. So we presented that. And then we also, about 90% of the patients, including our most highly acute patients, would recommend Connections. And we always offer a survey at the end of the time that they're seen with us that they can complete. And so, yeah, we feel really great about the feedback we get as well.
And even on the individuals that you're transitioning to a higher level of care, I would have to think that there's a value to those higher levels of care places to receive someone that has been stabilized.
Yes, and I think prior to us launching in December, what we heard from the community was, there's no way you're going to place somebody in inpatient in 2359. There's no way you're going to do it. There's no beds, no one's accepting. Like, we heard that at almost every meeting that I went to. And we are finding very little challenges placing people. But
I know.
but the percent that doesn't mean that every single person that comes in our door we're sending to inpatient either. The purpose of our level of care is to not do that. And so the good news is some people are being stabilized and going home, and the ones that we do have to send, we're not struggling to place. So
That's really
That
good
is
news.
great.
Including youth, which can
is
be a
great.
barrier.
Yes, our team works really hard.
Yes.
Placing the youth if they have to.
So here's like the $1 million question.
Yes.
How are you doing with moving towards sustainable funding?
Do you want to talk about the funding question?
It's not,
I mean, we're getting there. Yeah.
Like, we've got a grant that
Yeah.
Yeah.
time is ticking down on.
Yep.
and we can get you a follow-up on
and
that from
yeah,
finance.
appreciate
I
that.
cannot give
Yeah,
that
I'm like,
update.
do we have finance in our brain?
No.
But I think we did provide an update to the counties on third-party payer conversations, and we're still, our team is working on those. They are having them. They seem to be receiving positive feedback from third-party payers, and so that
Yes.
is a hopeful area. I think we provided that feedback like a week ago.
I just toured one too. Some of the payers are coming to tour
To tour the facility.
Oh, good.
Yeah.
So it's daily.
Yeah. And that's our business development team. So we
Yes.
will get,
But we can make sure that's added then
we'll follow
and get that to you guys.
Thank you.
For
Yeah,
sure.
thanks.
Yep. Did you have any questions for us?
No, but I think that when you talk about being able to diverse, and you also talk about not having a problem getting a bed,
I know everyone knows.
that is so important, because I would also be interested to know that end bed
Mhm.
is your ease, and I'm gonna put that right, in being able to do that because of that first level of care that people receive, because we don't have a person who's in crisis when they're going directly to the bed. Like, I would be very interested in, you've said, everyone has said this would never happen, you'd never be able to do it. So what is allowing it? What is really allowing that to happen?
I mean, I certainly think that it's been, you know, we can ask them, right?
I
So like,
think we
have-
should. I think
yeah,
we
I
should. And part of it, I also think is when a packet is sent, they've had a nurse assessment, a psych eval, a psychosocial, social determinants of health, a nutrition screen is all going to that in that packet saying, here's a patient that needs further stabilization based on X, Y, and Z. So I do think that might be, but I do think maybe
I can ask them.
Yeah,
I mean,
I think
like I
we
said,
should.
I interact with them very regularly. I also think that the relationships that we have built with the inpatient units and the ability to communicate with our staff while the patient is in treatment and actually providing treatment to the individual while they're with us, they're not just sitting, is also beneficial to them. You know, we had issues in the beginning with lab work, and what was in this community, what was a very normal thing was labs being run, received, and reviewed by the inpatient facility prior to accepting the patient. Connections doesn't typically take medically compromised individuals because medically compromised individuals should be going to the ED. And we have built a relationship with our inpatient units where if our team deems them medically stable, they're accepting without lab work. Like they are trusting the work that our team is doing. We are drawing them and then sending them to the inpatient units after they've accepted them. So we are really able to break down barriers that I think for a long time in the community is just, this is what we've always done. They've always gone to the ED, they've always accepted and needed labs, but we're able to have those conversations about, do you really need them prior to accepting? Is there something our team can review or run? And so we've been able to decrease like the necessity for medical clearance or labs being, you know, done elsewhere. So I think those are some really positive things that have come out of our relationships with the inpatient unit as well.
Because on the surface, that was what I was wondering, as you transition folks to those, is they have to be getting a better, just even the information and a more stable patient and a better, it's from a better start.
Right.
And is there or will there be a plan at the end of the year to address all of the hospitals, to summarize the performance and quite frankly, ask the hospitals for help in funding?
Okay, so first question, I think there'll be conversations with them. I think the number one thing we are looking at right now in partnership with the hospitals is around the conversation of what's always been done, but what's possible, right?
Okay.
Because an individual in an ED, essentially that's an outpatient,
same
environment,
licensure.
same licensure with us. And so is there a world in which a patient could be medically stabilized and then transported to clinicians for behavioral health? There's a lot right now around conversations around EMTALA or transportation issues or that not being possible. But what we would love to see is someone who presents at the ED not being turned away, but being treated medically and there being an identification of, okay, this is a behavioral health concern and we have a local provider who can do that. And so transferring them to us to relieve the pressure of the length of time the individual is in the ED. And so we want to have those conversations with our hospital partners, because if that's possible, as we move into this pilot project with EMS, which is really exciting, we can collect that data at the back door that EMS is bringing. And the two data points we're collecting are how many drop-offs and then how many of those people need to go to ED. And so we would hope to see people coming and no one going to ED. So the EMS, it means they're identifying the correct patients for connections, right? And so as we roll that out, I think those are two projects that could be happening at the same time. So when EMS regulations are updated and make it capability for EMS to drop off, then we have our hospital partners are also able to make that transfer. And so I think there's a real opportunity with our hospital partners to continue to decrease Because a community who is comfortable presenting at an ED will probably, for a while, still present at the ED. And so can we identify that at the medical clearance level and transfer to help with that? The funding piece, I don't know.
But inadvertently, you are helping them.
Yes.
You know, with their
Yes,
cost
absolutely.
structure, like.
Yep,
It's
Significantly.
Significant.
absolutely.
And
Different.
you're making really good progress on the EMS reg update.
Yes.
Yeah, so we met with Dr. Bledsoe today. It is certainly a heavier lift than I think the initial conversations anticipated, because we want to do it right. We want to make sure that it is done right. And so our launch date is in July right now. We're in the final stages of training EMS and making sure that they are comfortable with the flow of who to call, where they're dropping off, what they're receiving at the back door. In addition to making sure that we have adequate time to train our staff on all shifts in all disciplines,
Right.
to make sure they know who they're receiving, what they're handing over to EMS, what the phone conversation looks like. And so we're really excited about that. And our conversation with Dr. Bledsoe today went really well.
Just for the commissioner's awareness, that's Life Team in Harrisburg, though, correct? So
It's
we would-
UPMC Life Team. So if they,
Yes.
they can transport from any county. And I think when we met with Holy Spirit ED the other day, they sometimes see Life Team. And so
Yes.
Life Team can cross counties. They're primarily in Harrisburg. But the benefit to UPMC Life Team is two things. One, they're absorbing the costs and we're collecting data for advocacy. So Dr. Bledsoe is the state medical director, and so he is working diligently on changing the language and the regulations to allow for an alternative drop off from the ED, and changing a couple different ways that a call can end, so that there may even be warm handoffs from an initial EMS call that might not require medical attention to like our mobile team. So there are a couple different things that need changed in the regulations, but he is eager to collect data and advocate for that.
Oh, I didn't even think about a call that EMS doesn't, if they're forced to respond when they
Yeah.
may not need to.
Right.
Yeah, I didn't even think about that one. Very good.
That was very thorough.
Thank you.
Yeah, thank you, and
Very
thank you for being
And
flexible
please,
on the
if
fly.
If you
Oh,
have any
anec-
other questions.
And
please reach out.
anecdotally, we have, I think both Jean and I have received really positive feedback from police departments as it relates to the drop-off process.
Awesome.
And I really believe that it's just a matter of that word getting
Yes.
Absolutely.
out,
Yes.
even more.
Yes. It's constant education.
And I'm out there, I promise.
And I mean police officer to police
Yes.
officer.
That's where it really matters.
Through
Yeah.
the departments
Yes.
and that sort of thing.
Yeah.
Absolutely.
So we appreciate.
Yes, thank you for having us.
Yes.
Thank you. Yeah, thank you
And
for
we'll
your
be
time and coming in.
We're
Yeah,
so
We'll see you next week.
back.
Thank you.
All right. Is there any other business to come before the board at this time? Seems not. Hearing none, I'll entertain a motion for adjournment. So moved. We are adjourned. Thank you. Thanks.